Well, welcome to our continuing series on ethics in healthcare in the city of Ventura, sponsored by the Community Memorial Health System. Thank you very much, all of you, for coming here tonight. My name is Dr. Jim Hornstein. I'm the chairman of the Bioethics Committee at the Community Memorial Health System, and it is really my pleasure to moderate tonight's program. Tonight's topic is going to be exciting and challenging. It is titled, Religion and Medicine, Is It a Healthy or Holy Relationship? I know you are in for an exceptional evening because we have amazing speakers and an engaging topic. However, to be blunt, I need to begin by offering an apology. In fact, I have an apology actually to my mother. You see, years ago, quite a number of years ago, my mom taught me never to talk about religion, politics, or drugs publicly. I think she was afraid that no matter what I said or what was said, inevitably you alienate or anger a few or even a lot of people. So tonight, if any of you see her, tell her, I'm terribly sorry, Mom, and in fact, I'm sorry twice, because tonight we will be talking a lot about religion and its important place in American society, and in 2 months, as you see on your chair, we will be hosting our next talk on medical marijuana, on drugs, whether medical marijuana really is a useful medication or whether it's just a backdoor excuse to get high. Either way, religion and drugs in public. So again, Mom, I'm terribly sorry. Truthfully, however, my mom was probably right. These topics can, in fact, be both divisive and alienating. However, our ethics committee chose them not because they are easy to discuss in public, but rather because they are important to discuss. Now, why is it important to discuss? Because for many people, religion defines who we are as a person, how we come together as communities, what is our role in this world, and for many people, significantly, how do we partner with God or with a higher being? For many people, religion serves as a powerful guide to help us make some of the most important decisions we will ever be called upon to make in our lives. And not infrequently, those decisions are forced upon us when we enter into the world that I work in the healthcare setting. And unfortunately, I know from experience that many of you here today, from personal experience, have experienced those kind of very difficult and trying decisions. As we also know, serious illness often brings us face to face with many strong emotions and feelings. Some of those are our most deeply held hopes and dreams, our most dreaded fears, and our most cherished values and beliefs. These concerns about hopes and dreams and fears and values, while they may arise in our hospitals and on our clinics, actually belong more in the realm of religion and spirituality than they do in the textbooks or protocols that I follow in medicine. In the past several decades, our wonderful new medical technologies, and they are wonderful, and they are new, and they are exciting, have allowed us to do all sorts of incredible things to individuals to help their health. Even this past several days, I have inserted a tube into the lungs of an individual to help him breathe easier. That was a medical procedure. However, what medicine alone does not answer is whether we should put feeding tubes and breathing tubes in all patients, especially those who are dying terminal deaths from end-stage diseases. As a doctor, I know how to place a tube in a patient's stomach and artificially feed them. But again, should I do that in a patient who, let's say, has end-stage dementia, who then will spend the rest of their life trying to pull that very tube out? What have we done to help them? Technology alone is not necessarily the answer, and it does again fall to these very important questions of values and goals and fears and hopes. In addition, I've been taught to effectively relieve a patient's suffering, but should I go further, as some people have suggested, and aid not only in relieving suffering, but in aid that patient's death, even if that very patient asks me to help him? I think you get the point. In medicine, just because we can do something does not answer the perhaps more fundamental question of whether we should do something. These questions of should we and ought we do procedures are ultimately answered by trying to understand people's values, their morals, their beliefs, and their religions. And since Americans are overwhelmingly define themselves as religious people, many Americans look to religion as a guide to help answer these difficult and morally complex questions. So tonight, we have the wonderful opportunity to turn to three distinguished teachers to help us better understand how religion teaches us and guides us in the realm of human health, disease, and the difficult choices we will sometimes be asked to make. As has been our custom in these Ethics of Society series, our format is very simple. Each speaker will present their introductory remarks in about 15 to 20 minutes. We will then have an opportunity for a question and answer period, also running about 15 minutes. Now, for those of you in the audience, this is an interactive opportunity. If you can think of a question during a presentation, please raise your hand. You will be given a piece of paper. Fill out your question, and an usher will pick it up from you and give it to me for our question and answer period. After the conclusion of the question and answers, we will then give each of our speakers an additional 3 minutes to give us any final thoughts they have to pull the subject together. So now, if it's okay, and everybody has a seat and something to eat. Everybody have a seat, something to eat? Good. Let's go ahead and begin. Our first scholar is Professor Rabbi Elliot Dorff. Professor Dorff earned his PhD in philosophy from Columbia University and was ordained as a conservative rabbi from the Jewish Theological Seminary of America. Rabbi Dorff has published over 200 scholarly articles on Jewish thought, law, and ethics, in addition to writing over 17 books, which include To Do the Right and the Good, A Jewish Approach to Modern Social Ethics, which won the National Jewish Book Award in 2002, in addition to Matters of Life and Death, A Jewish Approach to Modern Medical Ethics, which he was a finalist for another National Jewish Book Award. Currently, Professor Dorff is the rector at the American Jewish University and is a professor of philosophy for undergraduate and graduate students. In addition, for the past 30 years, he has also been a visiting professor at the UCLA School of Law. Now, in addition to the many other honors and accomplishments, including 3 honorary doctorates, Rabbi Dorff had served on the Ethics Committee of Hillary Clinton's Healthcare Task Force in the early 90s, in addition to testifying at President George W. Bush's National Bioethics Advisory Commission in the late 1990s. Now, in addition to all of these professional accomplishments, Rabbi Dorff is married to his wife Marilyn for 48 years, has 4 children and 8 grandchildren. He volunteers his time freely throughout the Los Angeles and Southern California area, and in my opinion, is probably one of the nicest and kindest persons I have ever known in my life. Ladies and gentlemen, our first distinguished speaker, Rabbi Professor Elliot Dorff.
Well, it's appropriate to apologize to your mother on the night before Rosh Hashanah. When we start the 10 days of repentance, I mean, I guess you ask God for forgiveness, and I suppose also your mother. Absolutely right. Okay. What I'm going to do in this introductory remarks is sort of give you a kind of general introduction to how Judaism understands medical ethics. And I'm going to leave it to the question and answer period for you to ask me some specific questions that are on your mind. So first, two introductory comments. One is, why Jewish medical ethics? What's wrong with regular medical ethics? And the answer is that there's nothing wrong with regular medical ethics, but what we call regular medical ethics in America is based on Western liberalism. Maybe the best way for you to think about this is think about the word religion. The L-I-G in the word religion comes from the same Latin root from which we get the word ligament. Anybody know what a ligament is? Yeah, it's connective tissue, right? And sometimes when a woman has had as many children as she wants, she has her tubes tied. That's called a tubal ligation. It comes from the same Latin root. And what religions do, among other things, is that they give you a big picture of who you are as an individual and who you are in all your connections to your family, to your community, to the larger human community, to the environment, and to the transcendent element of human experience, which in the Western traditions is imaged as God, and the Eastern traditions imaged in other ways. But what each of the various religions does is that it gives you an idea of who you are in all of these connections, and also what kind of a person and what kind of a community you should strive to create. Right? So each of the various religions of the world is doing that. And obviously, we're talking about human beings in all of these religions, so you would expect some overlap. But there are real differences among the religions of the world as to what the ideal person looks like. I mean, is the ideal person married, for example? Right? In the Catholic tradition, you have priests and nuns. In the Buddhist tradition, the priests are not married. In my tradition, when I was in rabbinical school, it was all men, and we were told that we'd better get married while we were in rabbinical school, because if we didn't, then the sisterhood would make sure, within the first year that we were in a congregation, that we would be married, and so if we wanted any choice in the matter, we'd better do it now. Okay? That's the other end of the spectrum, right? In the various religions of the world, is everybody supposed to be educated, or are the secrets of the religion held only by the elite, as in Mormonism, or again in Buddhism, right? Whereas in my tradition, already Deuteronomy 31 says, once every 7 years, men, women, and children should hear the Torah read and explained. So my tradition very much sees education as a very important piece of what the ideal community is like. Similarly, you can ask those same sorts of questions. What's the role of work in life? What's the role of play in life? What do you ultimately hope for? And when you do those kinds of things, you see that the various religions of the world have different understandings of this. And similarly, what's the role of medicine in life? Will vary from one religion to another, and not just from religions, but also secular philosophies. Things like Western liberalism, existentialism, Marxism, right? Secular philosophies also give you a big picture of who you are and what kind of a person you should strive to be and what kind of a society you should strive to create. American secular ethics, the medical ethics, is based on Western liberalism. Right? We hold these truths to be self-evident, that all men are created equal, they're endowed by their Creator with certain unalienable rights, and that among these are life, liberty, and the pursuit of happiness. What am I quoting? The Declaration of Independence, right. Jefferson cribbed that from John Locke, who had written that about 100 years earlier, except that Locke had said life, liberty, and property, and Jefferson said life, liberty, and the pursuit of happiness, and you can imagine how many doctoral dissertations have been written about that one. But I'm an individual with rights in the American understanding of things, right? So therefore, the gold standard in American medical care is, what does the patient want? Right, I've been a member of the ethics committee at UCLA Medical Center since the mid-'80s, and especially on end-of-life issues, the real question is over and over and over again is, what does the patient, or what did the patient, if the patient cannot express him or herself, what did the patient want? And every once in a while, I just can't stand it anymore, so I say, You didn't give him what he wanted through the rest of his life, so why are you so interested now, right? So we laugh about it for 2 minutes and then move on, because that ultimately is going to be the determining factor as to what should happen with a particular patient, right? In the Jewish tradition is much more communitarian, right? It's much more, we are members of a community, a very thick community. And it's not just a voluntary community. In America, you can decide to be part of a community or not. You know, to be a member of a church, synagogue, mosque, whatever, or not. To be a member of a health club or not. For that matter, it's hard to become an American citizen, but if you are one and you have not committed a felony, you can go to any consulate or embassy, American embassy outside the United States, fill out, I think, a 2-page form and renounce your citizenship as an American. So even citizenship is a voluntary thing in America. Whereas in the Jewish tradition, if you were born to a Jewish woman or you converted to Judaism from age 13 on, then even if you later convert to another religion, if you convert to another religion, you're an apostate, so you lose all the privileges of being Jewish, but you still have all the responsibilities. This, ladies and gentlemen, is Jewish guilt, okay, right? Which is very much part of my tradition, although I understand the Catholics really have it. But, okay. So I mean, the point that I'm after here is that when you look at the various religions of the world and the various secular philosophies of the world, they will give you different understandings of the role of medicine and the role of health and health altogether. And I'm going to talk about exactly how Judaism understands those things in a moment. But the first thing that I wanted to point out is that why even talk about a Jewish medical ethic altogether? And the answer is because it's different from Western secular ethics. It's also different from Catholic medical ethics, from Lutheran medical ethics, from Buddhist medical ethics, and so on down the line. Second introductory thing that I want to point out is that that medicine has exploded in its ability to do things over the last 100 years. Well, in 1900, life expectancy in this country was, what would you guess? 45, roughly, right? Roughly 45 years of age in 1900. In the year 2000, just 100 years later, life expectancy in this country was 75.8, actually. Let's say 76. So we went from 45 to 76 in 100 years. Now, most of that is not what you read about in the newspapers. Most of that is public health measures. Things like indoor plumbing. My wife and I were at a conference in southern India at one point, and you see all these open sewage pits, and you see flies all over the place, and you sort of wonder why people are not sicker than they are, right? Things like public health education. You're being taught that smoking is bad for you, that alcohol abuse is bad for you, that certainly drug abuse is bad for you and the like, right? And now obesity, right? The various kinds of public health measures, which are not only just educational, but in law. So if you, I still remember I was on sabbatical in 99, 2000. I was teaching in New York, and like page 15 of the New York Times, they had a little article that Maine was the 4th state to ban smoking in public places. But only California, as of 1999, also banned smoking in bars, right? Now, if you make it really difficult to smoke, right, through laws and through things like that, then less people are going to do it. And it has real effects. I mean, there are about roughly now 21% of Americans smoke. The state with the least amount of smoking is, what would you guess? Utah. And now you understand why, right? Okay? 8%, 8.8% actually. But the second smallest amount is California, at 14%, which is obviously a much more diverse population and a much larger population, and that's public health measures, right, that have done this. Similarly, vaccinations that have very much reduced a lot of diseases and things in that order. So it's public health measures that have primarily led to our living longer. Second most important thing is antibiotics. I've had bronchitis 20-some times in my life, and I'm still around, right? Whereas my father had a brother in the United States in the 1920s. He had bronchitis, it became pneumonia, and he died, right? I mean, that's exactly how important antibiotics have been in our ability to survive diseases of various sorts. And it's only really in a tertiary way, if we're talking about numbers, that all of the new things have come into play in terms of why we live longer, things like organ transplants and microsurgeries and the like, right? But my mother gave birth 2 years before me to a baby boy that was a blue baby. What that means is that the wall between the auricle and the ventricle of the heart didn't close at birth the way it's supposed to. And so his oxygenated blood mixed with his non-oxygenated blood, that's made him blue. And he died 2.5 months after he was born. Now we have the surgery for that, right? So had he been born not in 1941, but in 1991, he would still be alive, given that. So the new things are indeed saving people's lives. But if you're talking just statistically, public health measures are the most important thing that have led to that. Second most, antibiotics, and then also these new kinds of things. The question, though, is, if we're now taking an ancient tradition that didn't know about heart-lung machines or didn't know about microsurgery, and you're now trying to apply it to these new situations, you can't just look it up in a book, right? Because the book doesn't know about all of these things, whatever your book is and whatever your religious tradition is. So the question then becomes, does that mean that the tradition has nothing to say about all of these new medical questions? Well, there are three possible answers to that. One possible answer on one end of the spectrum is, if it says nothing about it, it has nothing to say, right? In which case, the advantage of that is that you're being honest. It says nothing about the particular issue. And another advantage with that particular view is that you can do whatever you want, right? The disadvantage of that is that it makes religion completely irrelevant to an awful lot of decisions in life, because it's not just in medicine, it's also in, tradition doesn't know about the internet. It doesn't know about business deals done by the internet. It doesn't know about, iPhones and all of that. So if you're going to take that position, that if your tradition says nothing about a given issue, that it has nothing to say, you're going to make religion completely irrelevant to an awful lot of things in life, which is very problematic, because you look to your tradition for at least some moral guidance. The other end of the spectrum is turn it over and turn it over again, everything's in it. In other words, by hook or by crook, you're going to interpret your tradition to give you guidance on all kinds of things that never even contemplated. The advantage of that is that then you get a linkage between your tradition and whatever the issue is, right? So your tradition becomes relevant to everything. The disadvantage of that is, number one, you're being dishonest about your tradition. The tradition really didn't say that. And what you really are doing is what's called eisegesis instead of exegesis. You're reading into the tradition whatever it is you want to read into the tradition. So you're not getting any guidance from your tradition. You are just making your tradition say what you want it to say. You follow what I'm talking about? So those are the two ends of the spectrum. And what I would argue for in this book, Matters of Life and Death, in the appendix, is for a different way of dealing with this. Namely, that sometimes, at least my tradition, has some very specific precedents about certain medical issues. Okay? It has very clear precedents about the status of the fetus, for example, that go back to the Torah itself. Let alone later rabbinic understandings of things. But in a lot of cases in medical ethics, it doesn't have precedence. So then what do? Well, then you do what I call depth theology. That is, you look to the underlying principles of the tradition and the underlying commitments of the tradition. How does it conceive of things, and what are its values? Right? You look at the underlying concepts and values of the tradition, and you apply those. Okay? So then the question becomes, well, what are the underlying values and concepts of the Jewish tradition vis-a-vis medicine? In the second chapter here, I talk about 7 of them, but tonight I'm just going to talk about 3, just so that you get a sense of what this is about. So one underlying principle of Jewish medical ethics is the body belongs to God. Okay? Now this is already different from American secular ethics, because in American secular ethics, to whom does your body belong? To you, right? And you have the ability, this is the Nancy Cruzan decision of the Supreme Court in 1990, if you are an adult, you have the ability to refuse all medical treatment. You may not do that for your children, that's a whole other matter, okay? But for you yourself, you have the right to refuse anything. You don't have the right to demand everything. That's a whole other matter, right? But you have the right to refuse anything because your body belongs to you, okay? And that's why what does the patient want becomes the gold standard of American medical care, right? In the Jewish tradition, God owns our body. We have it on loan, and we lease it, actually, during the course of our lifetime. So it's as if you were renting an apartment, okay? You have, on the one hand, you may not destroy the apartment. Why may you not destroy the apartment? Not yours. And of course, the medical analogy would mean you may not destroy your body. You may not commit suicide, okay, because it doesn't belong to you. Similarly, you may not damage or injure your apartment any more than normal use would require. So, in the medical analogy, you take risks in life. What kinds of risks may you take? May you, I don't know, may you go skiing? Well, yes, because even though there are injuries, there are injuries that come with skiing and sometimes even death, right? But by and large, if you learn how to do it and you stay on the paths that are marked, you're fairly safe. May you go bungee jumping? Well, that's a stretch. I couldn't resist. Right. Actually, bungee jumping is safer than skiing is. But you understand the point. I mean, but a more serious question is, may you drive a car? Right? I mean, that's frankly more risky than either of the two above, right? And so part of the issue is, how do you define the risks that are acceptable in your life that God would allow you to do? And the basic idea is, if it's risk that many people take and are safe with it, then you're allowed to take those risks, if not, not. Okay? But you're not allowed to damage the apartment. On the other hand, you have obligations to take care of this apartment. So rules about proper diet, exercise, hygiene, sleep. In the American understanding of things, why should I exercise? Because I'll feel good. What else? I'll live longer. What else? I'll look good. I'm maintaining the, well, that's, yes, okay, good. Right, I am maintaining the apartment. That's exactly right. I also, by the way, will have, I'm more likely to be employed. We know that now, right? Because my health care insurance will probably be less, okay? People will like me better if I'm fit than if I'm not. All kinds of practical reasons. This is American pragmatism at its height. Practical reasons why I should do it. But if I don't want to do it, let's say, all right, here's my Achilles heel. I want to eat a half a gallon of ice cream every night of the week. And if you're doing it, it might as well be mint chocolate chip, right? Or Cherry Garcia. That stuff is so good. Anyway, all right. But I will gain 500 pounds in no time. And there is no American law that says I may not eat a half a gallon of ice cream every night of the week, right? I might be stupid. Okay, but there's no law that forces me not to. On the other hand, in the Jewish tradition, I have an obligation to God to take care of my body. So that means things like proper diet and exercise are things that I must do even if I don't want to do them. So I have to avoid that half gallon of ice cream either by never buying it in the first place. That's the really important thing. Or by avoiding it simply because I have a duty to God, a fiduciary duty to God, to take care of this apartment of mine called my body. All right? So you can see some very different understandings of things if my body belongs to me or my body belongs to God. Second underlying principle, we are integrated wholes, we human beings. Now, our body, our mind, our emotions, our will are all integrated within us, and they affect each other. Now, you might say, well, that's obvious, but it's not at all obvious. If you look at Western philosophy, starting with people like Plato, there is a major dichotomy between the body and the mind, right? The body in Plato is the animal in you. The mind is the distinctly human in you. And they are completely separate, one from the other. So much so that in Western thought, a standard issue is the mind-body problem. Namely, if the mind and the body are separate, how are they at all connected? Descartes thought that they were connected in the pineal gland. It's a gland in your head. That was the magic place where the mind and the body were connected. But to this day, I took a course when I was in graduate school on the mind-body problem, and you get all kinds of issues as to how they are connected. And to some extent, this really affects this affects medicine in a way that I'll just show you in a moment. But in the Jewish tradition, well, I'll tell you a story in the Talmud. A man has an orchard. He leaves it in the watch of a blind man and a lame man, and he says, "Don't eat of any of the fruit of the orchard." So, and then he leaves. And then the blind man says to the lame man, "This is easy. I'll put you on my shoulders. You'll show me where to go. We'll eat of the fruit of the orchard. They'll never figure out how we did it." So that's what they do. The owner comes back sometime later and sees that some of the fruit is missing, and he says, "I thought I told you not to eat of any of the fruit of the orchard." And the blind man says, "I couldn't possibly have done it. I can't see where it is." And the lame man says, "I couldn't possibly have done it. I can see where it is, but I can't get there." So the owner takes the lame man, puts him on the shoulders of the blind man, and says, "This is how you did it, and this is how you will be judged." Similarly, says the Talmud, the body says, "I can't possibly lead a person to sin, because without the life breath within me, the neshama within me, I can't move. I'm simply like an inert stone." Okay, and a stone can't sin. And the life breath within one, the soul, if you will, right, says, "I can't possibly lead a person to sin, because without the body, I'm just like an ethereal bird that has no substance whatsoever." So God takes the soul, throws it into the body, and says, "This is how you were created, and this is how you'll be judged." Now, it's a simple story, but what it does is that it articulates a Jewish understanding of things as being, we are completely integrated, which means what? That the way we think and the way we feel and what we desire all affect our physical being, and vice versa. Our physical being is very much connected to how we think, feel, and will. And so consequently, when you're doing medicine, what does that mean? It means you're not, if you're a doctor, simply treating the body. You're treating the patient. You're treating the person as a patient, right? And you have to find out from the patient all kinds of things that are not directly connected to the body in order to be able to do good medicine, right? That, of course, takes time, and that's really problematic in the contemporary economic environment. But there are all these studies that have been done recently about American medicine where patients don't trust their doctors because their doctors are there for literally 5 minutes sometimes, right, and are listening for about 12 seconds, right? That's an exaggeration. It really is. But still, I mean, there's no leisure that doctors have under the current economic conditions for actually finding out what's going on. And the patients who end up trusting their doctors are the ones who think that their doctors have actually listened to them. Okay, but that takes some time. And by the way, good medicine, good diagnosis also takes some time, because some of the things that the patient will tell you only 10 minutes later after the beginning of things, right, turn out to be the really important things about the patient's physical condition. And also, by the way, we have some very good evidence. What percentage of simply prescriptions, I'm not talking about hard things like going on diets or stopping smoking, but simply prescriptions for pills. What percentage of prescriptions for pills do you think patients actually fill and take? Yeah, about 50%, okay? Now, some of it has to do with language problems. The doctor's speaking English and the person is speaking some other language. But a lot of it has to do with the doctor never had time or never did explain why you're taking this, right, and what it's supposed to do. Some of it is the doctor never realized that you don't have the money to buy it. Okay, all of those kinds of things, right? So seeing the person as an integrated whole and as a patient is really important in medicine. I was on a curricular committee for UCLA Medical School in the early 90s, where they created a program called doctoring, which is required of all medical students at UCLA for all 4 years of medical school. And what it is a series of vignettes in which the medical students are interacting with people who come with different things, right? So I remember the first one we created was a 15-year-old woman, I should say, who complains of stomach problems. You are the doctor. You diagnose her, and she doesn't have stomach problems at all. She's just pregnant. Okay. Now, if she were 18, it would be better, and if she were 12, it would be much worse. Okay, but she's 15, otherwise in good health, but she is Hispanic and Catholic and unmarried. And so all of the issues that have to do with her health and that of her fetus have to do with the fact that she is Catholic. Does that mean that an abortion is out of the question? Probably, but you never know. I mean, I'm co-chair of the Priest-Rabbi Dialogue in Los Angeles. I've been part of it since 1973, and the American Church is the Pope's loyal opposition, as my priest friends say. But probably an abortion is out of the question. She's Hispanic. Is she going to get kicked out of her house? And if so, where is she going to have this baby? Probably not in the Hispanic community. She probably won't be kicked out of her house. In other kinds of Catholic communities, she might be. You had these homes for unwed mothers and all of that, right, in years past. And she's, she's single, clearly. So where is she going to have this baby if she's going to have it? What is she going to, is she going to give it up for adoption? Is she going to keep it? Where's the man in all of this? Right? All of those things really matter in terms of her own health care and in terms of that of her fetus. Similarly, on this issue of being integrated wholes, right? Not only within yourself, but within your community. So what does that mean? That means in the Jewish tradition, for example, there is a commandment that you have to go and visit the sick. Now, why is it that you and I, and I'll say it straight out, that you and I don't like to visit the sick, especially when they're in hospitals? Why don't you like to do that? Staph infections, absolutely right, okay? Probably the most dangerous place to be for that. Why else don't you want to do it? Depressing, good. Why else not? I'm sorry? It's frightening, yes. Go ahead, why else not? You don't know what to say, which I'm going to come back to in just a moment. Exactly right. And then, of course, there's the schlep of it all. Right? You have to go to the hospital, you have to pay for parking, you have to find out where the patient is, and then when you get to the room, what's likely to be the case? They're out for test or they're sleeping, right? In which case, they're not encouraged to come back. But let's say the person is indeed awake, okay? So then the question is, what do you say and what do you do? The Jewish tradition actually has some very important advice. Number one, sit down. And doctors here, watch this. Why? Because if this is the patient and this is you, what does that body language say? I'm superior to you. I'm in power. You're not. That's the last thing you want to say to a patient. So you're supposed to sit down. Actually, before several centuries ago, people were lying on beds, on mattresses on the ground. So you were, the text, Maimonides, who was himself a physician, 12th century, says you actually have to lie on the ground so that your head is not above the patient's head. Okay? And then, what do you talk about? Well, you talk about the same sorts of things that you would normally talk about if the patient were well. So if you and the patient share an interest in sports, talk about that. Movies, books, communal business, synagogue or church business, whatever, talk about those things. What are you saying to the patient when you're talking about those things? Yeah, first of all, you are an adult, and I'm treating you as an adult. Second of all, even if your prognosis is terrible, at this moment in time, you and I are interacting as adults, and that I really take your position very seriously. Because illness is, first of all, isolating, and hence the commandment to visit, right? Illness is also debilitating, and therefore sit down and don't reinforce that sense of disability. Illness is also infantilizing. Right? And so you want to talk about adult things, not, just take my word for it. Both patients and visitors tire of talking about the food and the weather in about 3 seconds. Okay? So you talk about that. You talk about things that you would normally talk about. And finally, illness is boring. Right? So if you have a long-term illness, most of us are going to die of long-term illnesses and not of acute illnesses. Right? So, but if you know that people are coming today to talk about the things you like to talk about, then that's a reason to get up in the morning, right? So you need to, so this notion of visiting the sick is also part of this whole idea of the person as an integrated whole. And then finally, the last thing I'm going to talk about tonight before the questions, the third underlying principle is that medicine is a good thing. That it's not the case that if we do medicine, we are taking away God's prerogatives, as some traditions understand it, but rather we are the partners and agents of God when we help people stay well, first of all, prevent illness, and also when we cure illness. And so consequently, the Talmud ultimately says that a Jew may not live in a city that lacks a physician. Because if you live in a city that lacks a physician, then when you get ill, you cannot get professional help to take care of this body of yours that belongs to God. So Jews have had a virtual love affair with medicine for the last 2,000 years. A lot of rabbis who were also physicians in the Middle Ages. Doesn't happen very much anymore because rabbinical school still takes more or less the same amount of time, but medical school takes much, much longer. I was at a conference at the University of Virginia where the dean of the medical school said that in Mr. Jefferson's medical school, how long do you think it took to become a doctor? 1. Okay, because in the 1700s, that's all they could teach you, right? Now it's 4 years of medical school, 4 years of pre-med, 4 years of medical school, a year of internship, 3 years of a residency, and very often a postdoc, right? So going to rabbinical school and medical school doesn't happen very much anymore, right? But there is a very strong sense in my tradition that medicine is a sacred profession. And that that therefore, for many years, every Jewish couple wanted to have their daughters marry doctors. Now their sons marry doctors, right? So I mean, there's a very strong sense of medicine not being taking away God's prerogatives, but rather being the agent and partners of God in promoting health. I'm going to be happy to take all your specific questions when the question and answer period comes up. And
Our second speaker is Father Dr. Luke Dysinger. Father Dysinger is an expert in Catholic moral theology and church history and is a professor at St. John's Seminary in Camarillo, which, by the way, has a front page article in the Ventura Star today. If any of you want to learn a little bit more about the seminary which Father Luke works at. Professor Dysinger received his bachelor's degree in religion at the University of Southern California. I did not know he was a Trojan prior to here. And he went on to graduate from medical school also at USC School of Medicine. He crossed a chasm and did part of his residency at UCLA and completed an interfaith experience, right? He completed his residency in family medicine and was board certified by the American Board of Family Physicians. Not quite through with his schooling, he crossed the Atlantic to attend Oxford University, where I don't know if they have a football team, but we call it soccer, right? But where he received his doctorate in philosophy in theology. He is the author of dozens of scholarly publications and teaches academic courses in marriage and human sexuality, healthcare and Catholic morality, and bioethical dilemmas at the beginning of life. In his spare time, Father Dysinger is an instructor in medical ethics for all the Catholic priests practicing in the Southern California area. I think you would all agree that as a doctor, professor, and priest, Father Dysinger is exceptionally qualified to teach us all about the Catholic perspective on healthcare and human illness. Ladies and gentlemen, Dr. Dysinger.
Thank you very much for the opportunity to follow Rabbi Dorff. Many of the things that he said about the development of the tradition and reflecting on ethical issues means that I can quite easily dovetail into that by saying that the Catholic tradition of healthcare ethics, what has subsequently come to be known as bioethics, has been going on for a very long time. Very early Christian theologians, already in the 200s and the 300s, were taking advantage of rabbinic reflection on questions like, when does life begin? How should we cherish life in the womb? Jews and Christians in the Roman Empire were known as being exceptional because they did not expose their infants. They did not believe that they had the right to kill children who had obvious defects of one sort or another, or who were of the wrong gender overwhelmingly being female. So from a very early stage, Christians reflected on the significance of life, and several principles became rather foundationally enshrined in subsequent documents and tradition. One is that life is a gift. It is not something over which we have control. God gives us life as a gift, and when life occurs in the context of marriage, it is also a gift, not a right. So the Catholic tradition would always emphasize the tremendous responsibility we have to safeguard, to take responsibility for the great gift that we have been given in our own lives and in the lives for which we may become responsible, particularly as parents. And another foundational principle, which is found very early on and continues to be reflected on throughout the Middle Ages and is clearly articulated today, is that the taking of innocent life is always wrong. There are no circumstances that can justify the direct, intentional taking of innocent life at any stage, whether at its end or at its beginning, because life is a gift from God. So, another vitally important and fundamental principle, which is even evolved into the question of a kind of a moral, ethical principle called the principle of double effect, is that we cannot ever deliberately intend to kill, but we must be aware that many human acts, all human acts, have multiple consequences, not all of which we can control, and that there may well be actions that are required, that are essential, which will have unintended secondary effects. And therefore, one can engage in acts intending to help, which may have a secondary effect even of causing death. I say that because it will kind of underlie principles connected with the beginning of life. But I'd like to focus this evening, and I suspect in our questions we may actually raise beginning of life questions. I'd like to focus on the, if you will, magisterial or official position on questions concerning the end of life that have been reflected on over a number of centuries. Questions like, are we always obliged to do everything that the doctor tells us we should do? The answer is no. And in fact, that conclusion was reached many centuries ago. Medieval theologians, and in more recent time, Renaissance theologians, considered the question in all of its ramifications and came to and continue to come to the same conclusion. You are not always obliged to do everything your physician says just because it's been recommended to you. We'll look at why that's the case in just a moment. The other vitally important question that one has to be aware of, and it's enshrined in some of these documents, is that life is a gift, and we are given responsibility for that gift, but we always act in freedom and with an informed conscience. Our actions are always intended to be engaged in a way that is as free as possible, as free from compulsion as they possibly can, and as informed as they can be by the various options that exist before us. And because life is a gift, because life is a precious gift from God, we're required to honor and to steward it. What I've given, for those who might wish it, on a little handout is an official statement from two parts of official Catholic teaching. One is the Catechism of the Catholic Church, which is not just a document intended to educate children, but is intended to be a compendium of doctrine drawing from the full 2,000 years of Christian tradition, crystallizing out many vital and central issues. And I've encapsulated a couple of points from the Catechism here before us, which might be rather different from what one imagines the Catholic Church teaches. Life is a gift. Life is a precious gift. We are required to steward it. But the other essential insight that characterizes Christianity is that life does not end at death. all of us are intended for an eternal destiny in which we will live in intimate union with God and one another. So if you don't like your neighbor, you better start. And in fact, some of the best definitions of what unpleasantness in the world to come might consist in are precisely meditations on exactly that question. When Jean-Paul Sartre said that hell is my neighbor, he was articulating exactly a concern that people today have. If your desire is to live in absolute and complete freedom and isolation from others, I'm sorry, you're in for a disappointment in the world to come. Catholics are convinced that we will live in a deepening union with God and with one another, and we begin now to live in a part of that unity and that union. So the choices we make involve both one another and they involve our relationship with God. And in regard to the end of life, there's a very foundational and fundamental principle that might be a little surprising to some, and that is that discontinuing medical procedures, and this is something that was talked about already in the 15 and 1600s. This is not a new principle. Discontinuing medical procedures that are burdensome, dangerous, extraordinary, or disproportionate to the expected outcome can be legitimate. In other words, you are not always required to do what your physician tells you to do if the consequences will involve burden, danger, and the word extraordinary is used, but there is no Vatican list of what is extraordinary and what is ordinary. That word depends upon the individual. And often the phrase morally repugnant is used to describe the fact that if a person has a profound and deep-seated revulsion about something that is being recommended to them, that may well be a legitimate reason for them saying, I'm not going to do that, even if it might hold the potential for sustaining or extending life. So it can be legitimate. It's the refusal of overzealous treatment. And notice the statement that follows, one does not will to cause death. One's inability to impede it is merely accepted. Because finally, we recognize we cannot keep ourselves from dying. We will all die. It's a question of what is morally and ethically expected, required, normal for an individual who has reached the end of life. And Catholic moral teaching would say very clearly and very specifically that as the end of life approaches, the obligation to do anything you don't like diminishes drastically. People at the end of life have the right to refuse anything they experience as burdensome or disproportionate. I do not define what is a burden for you. You can tell me what the burden consists of for you. Again, this is not some, theological opinion from a liberal theologian. It's from the Catechism of the Catholic Church. I wanted to point out one little phrase that is of particular importance, especially for Catholics who become nervous and worried when they think that the world is becoming a more dangerously liberal place. People were talking some time ago about a fear of death committees that might be created by the government to insist that certain people not receive care. And unfortunately, I'm afraid there has been a linking in some people's minds of the idea of committees that would refuse care with something absolutely fundamental and beautiful, namely palliative care. Treating a person's pain, discomfort, and experience of loss, especially at the end of life, with whatever that person needs in order to be kept comfortable. Palliative care is about treating symptoms, not about curing diseases, and the Catholic Church's approach to palliative care is here. Palliative care is a special form of, this is a very bad translation, disinterested charity. Disinterested means non-selfish. It means a love that proceeds from generosity. The Latin word is gratuitas, gracious charity. Palliative care is a form of loving. And if we could switch to the other slide, to the other text. Again, this is for anybody who might want it in a handout. This is from another kind of document that was assembled not by the Vatican, which the Catechism was, but by the North American bishops. And it's called the Ethical and Religious Directives Concerning the End of Life. And here, too, it's very clear, and it's restated, a person has a moral obligation to use ordinary or proportionate, meaning it's likely to do you good, it's likely to achieve the ends that have been described, means of preserving life. But proportionate means are those, and I've underlined, that in the judgment of the patient offer a reasonable hope of benefit, do not entail an excessive burden, or impose excessive expense. One can refuse care because it costs too much. This is a principle that was enshrined centuries ago, where people asked, if I want to leave a legacy to my children, and the physicians are telling me that I have to sell my property in order to take care of my health care needs, am I obliged to continue living at the expense of what I would pass on to those I love? And the Catholic answer to that was, no, you are not so obliged. Expense can be a reason for choosing not to undergo therapy. That sounds a little odd and a little un-American. But again, for certain individuals, that would constitute a significant burden. Well, we could go on and discuss these matters in a great deal more detail. The question of nutrition and hydration, the Catholic Church got a bad rap a number of years ago when the LA Times and other periodicals began misquoting a papal document that was intended to describe only the situation of the persistent vegetative state, a specific medical condition, which Catholic theologians and people throughout the world regard as a state of being profoundly disabled and in which a person should receive nutrition and hydration. The conclusion was, okay, Catholics always have to die with feeding tubes in place. That is false. No one at the end of life who experiences forms of medical care as burdensome, painful, expensive, morally repugnant is obliged to use them. And having said that, I think I'll wait till the question and answer period to carry on a little further. Thank you all very much.
Our third speaker is my dear friend, the Reverend Pastor Curtis Hotchkiss. Reverend Hotchkiss is the Director of Spiritual Care Services at the Community Memorial Health System. Reverend Curtis is a board-certified chaplain and is a member of the Association of Professional Chaplains. Reverend Curtis was the first and remains the only chaplain ever hired by the Community Memorial Health Systems beginning back in 2007. Chaplain Hotchkiss earned his bachelor's degree in ministry from the King's Institute and Bible College, and he received his master's degree in theology from the Andersonville Bible College and is an ordained Baptist minister. Reverend Hotchkiss provides spiritual care services at all Community Memorial Hospital and Health Systems organizations, including Community Memorial Hospital, Ojai Valley Hospital, and 13 centers for family health. He also serves as an associate pastor for the St. Paul's Baptist Church in Oxnard. In his spare time, Reverend Curtis is married to his wife Veronica, and together they are raising 5 beautiful children. What is not widely known is that Reverend Curtis is a lifelong sports fanatic. Although it has never been proven, many of us believe that the Los Angeles Dodgers and the Los Angeles Lakers find a place in his private prayers regularly. Ladies and gentlemen, it's my pleasure to introduce my dear friend and colleague, Reverend Curtis Hotchkiss.
Thank you, Dr. Hornstein, for that introduction, Rabbi Dorf, and Father Dysinger, and the members of the Community Memorial family, all of my friends. I must say tonight, when I read the list of the previous speakers and the speakers tonight, it reminded me of the story of the man who entered his mule in the Kentucky Derby. And when a lady came up to him and asked him, you don't really expect your mule to win the Kentucky Derby, do you? And he said, no, of course not, but look at the company he gets to keep. So I am very honored and humbled to be here with you tonight. And as you know, religion and medicine in connection with ethics is a passion of mine. Correlation between religion and healthcare as it relates to quality spiritual care to patients and their families. Now, I do not come here tonight with the pretense that I have all the answers or even that I have a scholarly or philosophical insight to provide them. I make no pretense of any of that, but as you know, I am a Christian clergyman, and I do bring my experience as a master's trained chaplain. And I've spent my career learning about the complexity of the human spirit, and I'm learning. And the more I learn, the less dogmatic I become. I'm on a pilgrimage of compassion and understanding, a journey to discover the human spirit. And I believe that though we may start from different perspectives or different vantage points, if we care to listen, we can understand each other's beliefs and each other's needs. I'm going to be talking about how to conduct a spiritual assessment and what happens when you come to the hospital. Now, you know, the doctor gives a physical assessment, but also a spiritual assessment is going forward when you come to the hospital, and I want to talk a little bit about that. But personally, I want you to know that I personally ascribe to the 10 Commandments, the Sermon on the Mount, and the Golden Rule. Those are things that I try to reference from. So first of all, spiritual care and its treatment is the missing piece of the treatment puzzle, because spiritual care is taking care of the whole person. When you come to the hospital, you know, the doctor is taking care of what you have. Spiritual care is taking care of who you are. CMH, the system, deals with over 70 different churches and synagogues and faith traditions. And it is a testament to the healthcare system that spirituality and religion is something that is very important to the hospital. When you come, your religion comes with you. But what I'm interested in is the spirituality. And everyone has a story. And I'm going to start off tonight with a quote from our illustrious philosopher, Mike Tyson, who says, "Everyone has a plan until they get hit." And that's true. We all have a plan until something hits. And in the complexity of the human spirit, what I want to talk about tonight is how it brings each of us meaning, purpose, value, and direction. And by understanding these 4 aspects, we can better identify our own spirituality. So as I'm going through this, I want you to think about yourself. Purpose and direction deal with the doing aspects of our spirituality, and meaning and value deal with the being. So, clicking through this, meaning, purpose, value, and direction are leading to our own spirituality. Doing is our activities that are important to us, and being are the relationships. The reason why I'm sharing this with you is because when you come to the hospital, you know the question they say, do you have a special faith tradition or religion? Well, that's what it starts with. But then we have to find out who you are. You've heard people say, what gives you meaning? What gives you meaning? Well, that's a very important question, and it has to do with relationships to your spirit, the things that are really significant to you, the things that are important, the existence, because we have 3 things that are our top things that we assess when patients come to the hospital. And what do you think the number 1 assessment is of patients in the hospital? Number 1 thing is fear of death or fear of the unknown. Fear. So it's very important that we understand what is meaningful to us, what is really important, and that deals with our relationship spirit. The mindful things, and I'm glad the rabbi spoke about this, the mindful things is a doing part of our activity, our education, our careers. Many times I'll ask people, Where are you originally from? The great part about my job is I'm able to connect with people where they're at. I care that you're having a procedure, but I more care about who you are. Because sometimes when you come to the hospital, unfortunately, you're the gallbladder in 417. But not to me. To me, you're Father Dysinger or you're Rabbi Dorf. You're not just the gallbladder. So your education, your career, and your recognitions, a lot of times when you come to the hospital, those things get stripped away. But it's important that as we treat the whole person, that we pay attention to that. Another thing that we're dealing with when you come to the hospital are your values, the things that are important to you, and those things are individual. I've always said when you've met one spirit, you've met one spirit. There is no two of us that are alike. We all have individual values that we hold dear, and we hold them at different measures. And that's important when we're doing a spiritual assessment, to find out what you value, what's important to you. And religion is one of those things. As I said, we deal with over 70 different faith traditions and synagogues. And what I do is I don't try to be the rabbi to you. I connect the rabbi to you. I connect the Father to you. And I try to be there to support you and your values. Another is our spiritual direction, and this is one that's very important. It's very important because this is one that you can take control of tonight. You can start taking control of your future by having an advance directive. By telling your family members and your loved ones what you want in advance and having that conversation. During my spiritual assessment, I have 5 keys. I call it the 5 keys to the spiritual assessment. And it's very simple. I walk into the room and I say, first of all, I'm walking into your bedroom, by the way. You wouldn't want to see me in my bedroom, and I know that you don't want to see me in yours, but unfortunately, when you come to the hospital, that's what we have. And so I walk in, I say, hello, my name is Reverend Hotchkiss. I'm with the Spiritual Care Department, and I just came to see how you're doing. And the answer to that question 98% of the time is fine. And then my next question is, well, what brought you to the hospital? Why are you here? And then the patient will say, well, I tripped over my dog and I broke my hip, and now I have to have surgery, and my husband's at home by himself, and I don't know who's going to take care of Cuddles, and I don't know what's going to happen here. And then I'll listen, because the doctor doesn't necessarily have time to listen to that or support that. And so I'll listen, and then after I've listened to that, I may say, well, who's your backup person? Who's supporting you? Who's helping you? And then they'll most likely tell me who it is, or I'll connect them with who I need to connect them with. I've called prisons in Iraq and different places all over the country to connect people and help reconcile and come up with some of those things. The 4th question I ask is, how are we treating you? Are we listening to you? Is the doctor communicating with you? Find an understanding of what's going on with the person. Whether they're comfortable with their treatment, or whether they're afraid, or whether they're mistrusting, or whatever the situation may be. And the 5th thing, and the final point is, do you have a religious connection or a spiritual background or something where I can help you? Would you like me to pray for you? Would you like me to, anything that I can do? And one of the things I always say is part of my living by the golden rule, I don't treat people the way I want to be treated. I treat people the way they want to be treated. That's the golden rule. The golden rule is to treat people the way that they want to be treated and listen to them. Advanced planning, financial security, fulfillment of life's goals, those things are all very important. So this is all going on during a spiritual assessment, during a conversation. I have 6 chaplains that work with me. I have a palliative care chaplain especially trained with end-of-life discussions. They discuss things with both the patient and the patient's spouse, Because when you're dealing with one patient, you're really dealing with about 3 or 4 people. How many of you know if you got sick today, you wouldn't be the only one sick? Your family's going to be sick too. Your spouse and your loved ones are going to be sick too. So after we have this conversation, and I find out who you are, and find out possibly, hopefully, how I can support your needs, then I share this assessment form, which I'm sure you can't see, with the physicians and with the medical staff. And on that form, the top of it says the source of spiritual concerns. Some of those things have to do spiritual support. Support may be prayer or your family or your minister, your friends, your life review. You may have a sense of peace alone. So we find the sources of your spiritual support and religious support. The second thing we do is we find what the concern is. What is the fear or what is the concern? And like I said, the first one is the fear of death or the unknown. There's also fear of healthcare procedures. The third most assessed thing is body image. Most of us are more concerned about how we look than how we feel. We're worried about how we look. And then the fourth is quality of life. And that's the number one question that we should be asking and be talking about. What is the quality of life that I want to live? What is the quality of life that I need to share? And quality of life. That is a very important part of our discussion tonight. I feel like in this ethical discussion, I'm in the middle. I'm a little bit religious and I'm a little bit healthcare. And I like it. I like it because there was a time when I was always in the pulpit. I was always in the church. But there came a time by serendipitous moment where I was called from behind that to get out and help someone. And now I love working in the hospital. And I'm very honored and privileged to do it. And I'm very proud of CMH. I'm proud of the hospital and the system that I work for, because this is a community. There's not one religion over another, and I've worked in a very prestigious staff in a faith-based institution. But we all are iron sharpening iron. We're all in it together. And I just really appreciate the fact that I have the opportunity to develop these connections with patients and their families. So I hope that this will kind of jar your own spirituality and identify the things that are important to you. And this is how we conduct these assessments. We don't conduct them behind just religion, because I don't know enough about Judaism. I don't know enough about Catholicism. I don't even know enough about being a Baptist. But I am learning. Amen. All right, so thank you very much for your time. And I'll Thank you. Thank you.
Isn't this terrific? So I'd like to go ahead. I've gotten some of your questions. I've got a couple of others, and I'd like to just get right to them. Of course, this seminar tonight could go on for hours, which of course we can't. But I would like to get to as many of these as we can, so I'll just start and we'll go for a bit. The first question, perhaps not the easiest question to ask our panel, is, number one, does God cause human illness? Let's get right to the point, okay?
Well, you want me to start? The most ancient should go first. And I think I am the oldest also. Yeah, I mean, what can I tell you? It's that's, by the way, the reason why you have to have grandchildren, right? Because they keep you young. I mean, I had my 3-year-old, there was parent-teacher conferences, my wife teaches, so she was busy. My son and daughter-in-law were busy at their work. It happened to be a day I wasn't teaching, so I had my 3-year-old granddaughter by herself for the day. And after lunch, she wanted a popsicle. And I said to her, Zoe, do you always get dessert after lunch? And she said, no, but you're supposed to spoil me. She got the popsicle, by the way. Okay, does God cause illness? Well, certainly, I mean, this is a very ancient question. I mean, you already get in the Torah itself, the 5 books of Moses, where God says to the people of Israel, if you abide by my commandments, then all kinds of good things will happen. And if you don't, then all kinds of bad things will happen, including illness. So that's, let's say, Deuteronomy, 7th century before the Common Era. Okay? But then Job, in the Bible also, you remember the story, right? He's afflicted with illness and does not accept the fact that he did anything wrong. And so already within the Bible itself, you have major questions about whether God either causes illness or is just in causing illness. I mean, this is not a recent question. This is very much an ancient question, and you get it's one form of what's called the problem of evil in philosophy, namely, why do bad things happen to good people, and the reverse, by the way, why do good things happen to bad people? That part of it usually gets lost. Yes, that's right, and so I mean it's a. And there are multiple answers in the Western traditions as to that question. I mean, I think a lot of it depends upon your theology in the first place. How do you conceive of God? And another piece of it has to do with, does God interrupt science? Right? I mean, in my tradition, the rabbis will say the world goes according to its custom. And so, God, even though there are interruptions in nature in some of the biblical stories, by the time you get to the rabbis, they will say that you may not depend upon miracles. Right? So, if you're talking about any issue, beginning of life issues, end of life issues, or the distribution of healthcare for that matter, you may not depend upon a miracle to intervene and make things all well. You've got to assume that nature will take its course. Now, is that God operating? Well, that is God who created the universe in certain sorts of ways. And one of the things that implies, this is Maimonides again, 12th century, God had a choice, either to create a world that was finite and that therefore had limits, and that therefore people born live their lives and die, right? And people have illnesses along the way. Or God could have decided not to create a finite world altogether, in which case none of us would be around, right? And God chose to create a finite world, but that logically entails that there be endpoints, that there be mortality. Because God, even though omnipotent, this is Maimonides again, cannot do what is logically impossible. You cannot create a world that is finite that doesn't have endpoints. Okay, so I mean that's what I'm saying, that a lot of this has to do with your own theology. I mean, I think in the Jewish tradition there's a very strong strand that goes back to Abraham about arguing with God. Abraham argues with God, Moses argues with God, Jeremiah argues with God, Isaiah argues with God. Job, of course, argues with God, and of course the rabbis argue with each other page after page of the Talmud, right? This is a very feisty tradition that I inherited, right? The standard joke is that where there are 2 Jews, there are at least 3 opinions. Okay? Except a man came up to me after a scholar in residence weekend and said, do you really need 2 Jews for 3 opinions? Right? So, I mean, it's there's a lot of protest against God in my tradition for people who are suffering and don't see that they deserve the suffering. But this is a long-standing problem and not one that can, at least in my own view, can be nicely resolved in any kind of philosophical way. And so the real issue is, how do you deal with the pain and suffering? How do you do with what Rabbi Hotchkiss was talking about? Right.
I wish I had a rabbi.
I'll just let it out. I mean, seriously, the kinds of things he was talking about are really critical in terms of talking about how do you respond appropriately to the question of why me, right? I mean, why is it that I'm suffering from this?
Another dimension that would sometimes be raised later in the tradition is the fact that we're trying to ask a question, and even asking the question, cause suffering, implies a temporal relationship. That is to say, we're speaking from within time, and we believe in a God who not so much exists outside of time, but is not bound by time in the same way we are. So there isn't really an answer to the question that could be given to us within our frame of reference that would do dignity, ultimately, to who God is and what God is. But that's a way of avoiding the question, really. The real, I would say, it's not so much a solution or the real place where people, I think, have to turn to God in the context of suffering is, at least in the Catholic tradition, God creates and maintains an exquisite and intimate solidarity with those who suffer. That is, God is in a perpetual relationship with all human suffering. No human suffering is not somehow embraced by and taken into an experience of God that ultimately will have meaning, even though at the time the individual may not experience any meaning at all. This has implications for how we deal with the sick. I can be absolutely convinced that your suffering or my suffering has meaning, but one of the least helpful or compassionate things I can do is to try to tell you what the meaning of your suffering is. I cannot do that in charity, but I can provide the kind of support that will allow you to articulate a growing sense of conviction that God has not abandoned you, that God is present with you in your suffering, and that some sort of strange alchemy, some sort of strange redemptive transformation is at work that means that whatever it is the individual is suffering is acquiring an infinite worth in a mystery we find impossible to express, that finally will only have its expression or its fullest, clearest meaning in the world to come, in a world beyond life itself. And that's not a cop-out. That's not avoiding the question. It's saying that what we experience now acquires a deeper, richer significance, which we as people who love one another and stand with one another can enable one another to begin to experience if we encourage one another to say what it is we are experiencing. Not trying to tell people what it means, but allowing people to articulate that meaning. So, is God the author and cause of suffering? God is not absent from any human experience. And God is the author of and continuing presence in all creation. But rather than asking, did God do this to me? Perhaps the more important question is God with me in this in a way that can help me enable this to be transformed into deeper meaning and an experience of compassionate love?
That's a very good question. I believe that God allows sickness. I see it every day. But I also believe that sickness is caused because we live in a polluted world. I believe that we don't live in the Garden of Eden as it was originally constructed. I believe that we are living in a time where the world is polluted. And not only that, we also, the Lord has set by certain dietary laws and certain things that we should do with our bodies. And we don't do it. And I can say that I'm the first one. We don't do the things that we should do to stay healthy or to be healthy. And if you don't live by those laws, and if you live in a polluted world, as a Baptist speaking, you can just prepare to get sick. Prepare to get sick.
It's called Cherry Garcia.
So I have another question. From your tradition, does prayer cure illness?
No, prayer doesn't cure illness. One prays on behalf of the ill for both healing of body and healing of soul.
Yes.
But there is no sense that, well, I shouldn't say that. In the ancient world, before modern medicine, if you're talking about 2,000 years ago, then there is actually a sort of sense that prayer has medical effect. There's a story, for example, about in the Talmud about Rabbi Yehuda Hanassi, who is the editor of the Mishnah. There's around 200 or so of the common, of the Common Era. He's dying, and his students are praying that he be kept alive. And the person, his maidservant, sees that he's suffering a lot, and so she goes up to the upper, the upper story, and lets a pot fall down. Then it breaks, and in the moment that it breaks, they stop their prayers, and he is able to die. Right? Now, the point of the story, right, is that, the presumption of the story is that prayer keeps people alive, right? But another piece of the story is that you can interrupt the prayer, you can interrupt the medical intervention in order to allow people to die a natural death, right? So yes, in that story, prayer keeps people alive. But as medicine developed over time, it became clear that prayer has certain functions in regard to both the patient and the people who are praying for the patient, but they're not medical functions. They're functions having to do with the patient's mental state. Because remember, we're integrated wholes in our communities, right? Mm-hmm. So the more that we have a sense of being supported by our community, in part by prayer, the more that the patient might, first of all, have a will to live, and therefore undergo the chemotherapy, which is terrible, right, and which is really, really painful. And if one knows, though, that people really care and are praying for that person, then one might do it. I was on a project one time on euthanasia, and this was before the cocktail of drugs for AIDS was discovered in 1996. This was 88 or something. And we interviewed a man who was 36 years old, who had AIDS and was going to kill himself. And he bought a gun and he used it, but it didn't go off. And then it happened that a friend of his dropped by that moment and saw that he wanted to kill himself, and set up a 24/7 vigil of his friends to make sure they didn't do it. And now we're interviewing him, and we say to him, "Do you want to kill yourself?" And he said, "Well, no, because my friends don't want me to." Right? There you see a very clear-cut example of how community support, including prayer, can help people deal with the ravages of a disease. Right? That doesn't mean that it will cure the disease, but it means, help them at least understand that they're supported in their illness. According to one of the codes of Jewish law, you have not fulfilled your obligation to visit the patient unless you've also prayed with the patient.
Well, Catholics certainly believe that healing and praying go together, and of course, I think Catholicism is renowned for shrines where people believe that these things take place. Lourdes is perhaps one of the most well-known, but it raises the very central question, and this is something that's being asked and reflected on constantly, and that is, what is healing? What do we think healing is? Does healing mean I go to a shrine with a particular illness and I'm healed if I don't have that illness when I leave? Is there some other kind of healing that could be much more foundational and significant? And indeed, one of the oldest definitions of prayer within Christianity is something that Clement of Alexandria actually seems to get from earlier sources, and that it is a lifting up of the mind of the deepest self to God. Prayer is about entering into union with and relationship with God. In prayer, we are drawn nearer to the Lord. And it is the Lord who heals, but the Lord is much more interested in a healing at a much more foundational and deep level than just the question of whether I have dermatitis or whether I have a severe infection. There is a healing of relationship, which, if our lives are eternal and bound up with one another and with God in eternity, that needs to touch those levels. And so the answer would be yes, insofar as prayer draws us closer to God, who is, and one of the most ancient titles for Christ was Christos Iatros, in Greek, Christ the physician, Christ the healer. We draw near to the God who has the power to heal, and we use the word salvation even to describe that act of being healed. But the healing is more than just a healing of the body. It's a putting right of a relationship that ultimately reaches out to all eternity. It has manifestations in this life, but they may not be the manifestations I happen to want.
I believe that prayer does work, and I believe that there is reconciliation in prayer. You may not receive exactly what you have prayed for in your illness, but you will receive a connection and a reconciliation with God. Whether it be in community or in a large crowd of people, or whether it be done contemplative and just by yourself, I believe that there is a reconciliation and a healing that can take place. Because I've seen patients that know that they have a very grave prognosis, but they're okay. And then I've seen other patients that are going to get well. And they're going to go home and they're going to go back to their normal routine, and I'll see them in the produce section in a couple of weeks, but they're very upset. I think that prayer can provide a reconciliation that if I get well, good. And if I don't get well, good. There's something that can come from our prayers in faith.
Couple more. Should the Bible be considered medically reliable?
Yes.
So put another way, is Bible medicine good medicine?
No.
Only if you don't mind confusing psoriasis with leprosy.
Yeah, that's right. Yes, that's right. Well, I mean, not only is the Bible not reliable, the rabbis weren't either. And as a matter of fact, it's not just Elliot Dorff telling you this. In the Middle Ages, there are certain cures that are in the Talmud. The Talmud was put together between 200 and 500 of the Common Era. So in the Middle Ages, you get, why don't these cures work here? And they say, well, that was Babylonia and this is France. So therefore, right, they don't work, right? And the times have changed, the places have changed, and therefore, we can't rely on the Talmud or the Bible, actually, for medical cures. What you do have in the Bible that actually does work is quarantine. In Leviticus 12:13, right? Mm-hmm. The way that they dealt with it was through quarantine. 1955, I got measles, bad case of it. And my sister and I were Milwaukee County Health Department came and put notices on our doorway, right? That we were stuck there and only my parents could come in and out for a month, right? 2 years later, I got chicken pox, same sort of thing, right? So, I mean, to quarantine communicable diseases, that was already in the Torah, in Leviticus. So that did work. In the ancient world, the only curative thing that they really had, and I should say, the rabbis also have a fairly good sense of some preventive medicine. They understood that you shouldn't eat too many sweets and too much meat, and you had to, and you needed to exercise. I mean, they knew those kinds of things. Their curative medicine was, in the ancient world altogether, I mean, was bloodletting was the primary thing, because they had a sense that diseases were borne by the blood. It turns out that the only disease that I know of that actually is cured by bloodletting was the one that my mother had, polycythemia. Too many red blood corpuscles, where you take a pint of blood every once in a while, and that deals with the disease. But otherwise, nothing. And did you see Dances with Wolves a number of years ago? Right? I mean, that takes place during the Civil War, and what they could do at the time was basically cut off the man's leg, right? And if he didn't die of the operation, he would die of the infections afterward. It was only after the Civil War that a man by the name of Lister figured out that if physicians washed their hands between procedures, less people died. So, I mean, and
we're still relearning that.
We're still learning that. Right. And that's 19th century, right? So you certainly should not expect that ancient text would give you very good medical advice.
There is in the parts of the Bible that are not necessarily in everybody's Bible. There is in some of the wisdom tradition, which you find in the Catholic Bible, actually an encouragement of trusting the physician, of believing that medical science will be of benefit to you, which is remarkable given the fact that in the ancient world there was almost nothing that actually cured specific diseases. There was opium to make you sleep, and there were drugs to make you vomit and give you diarrhea, but that was pretty much it. As far as actually treating specific diseases, it was pretty limited. But there was a willingness to entrust oneself to what you might call a developing science, to a developing openness to the possibility that the natural world might hold curative properties. And over the centuries, many centuries, cures and treatments would develop which could be embraced by religious people because they believed that God had created the world and that God had therefore put into the natural order things that might be of value. But it's not in the Bible itself, but in the kind of faith in the God who is to whom the Bible bears witness, that one would find the capacity to both trust in that. Now, is the Bible good medicine? Not for specific diseases, but there are ways of using the scriptures in meditation, in prayer, that can be profoundly healing interiorly to people, and those shouldn't be underestimated. But no, bits of the Bible applied to various body parts are not going to make them better. So, I don't think.
In the interest of time, I'm going to do something we've never done in these. We're going to go to a lightning round, just to hit a couple of very quick questions. So if you possibly can, with these very overwhelmingly complex moral issues, please answer them in the next 10 seconds. So number one, yes, if we had a countdown, please. Number one, would your tradition support physician-assisted suicide as practiced today in Oregon, Washington, Montana, and Vermont?
No.
No, in my tradition also.
No.
No. No, it works.
We're afraid of the buzzer.
Yeah. Should your religious tradition support or oppose healthcare reform?
Support. And actually in the 12th chapter of this book that you can buy outside, and I'll be happy to sign it, I talk about the distribution of health care. And because in the Jewish tradition, the community has an obligation to provide health care for its members, even though until now, health care was fairly cheap and largely ineffective until the middle of the 20th century. That's the reason why it was cheap. But nevertheless, I mean, you can find out from other parts of the Jewish tradition dealing with poverty and dealing with redemption from captivity that the Jewish community, that the community itself has the obligation to take care of itself, take care of its members, which the rabbis understand as an offshoot of the command, love your neighbor as yourself. So just as you have the obligation, just as if you needed health care and you could not get it except by the interventions of the community, you would want the community to provide it for you. So too, you have to provide health care for those who need it. So yeah, there's a very strong mandate in my tradition to to provide communal access to health care.
And support, of course, and most of the long-standing institutions for healthcare in the West were in fact run by Catholic religious or clergy or institutions, and still are in this country. Very large number, very large percentage of institutions are Catholic, primarily because of the obligation to be a part of both healthcare provision and reform. That is to say, ongoing provision of what's necessary. One big caveat that the American bishops have pointed out is, of course, that reform should not mean coercing people to provide procedures or to participate in acts which their tradition regards as repugnant.
Yes, my tradition believes in supporting the healthcare reform, and the basis of that is ethical justice, and everyone should have a right to health care and a physician and treatment at a hospital, and those type of things should be provided for everyone. I believe that.
Do you hear, I mean, this is actually quite remarkable, an absolute consensus on that's, yeah. Last question on the lightning round. What do you think your religion could teach young doctors in training today?
Well, one of the things I think that I've already mentioned is that the patient is a person, and that what you need, you're not simply treating a body. You're treating a full human being in that full human being's connections to family and community and the like, and with that full human being's hopes and fears and possibilities, both medical and non-medical. So the first thing I think that I would say to medical students is that remember that the person in front of you is a person and not just simply a body. Second thing I think I would say to medical students is that what you are doing is nothing less than sacred, and that with all of its issues, every profession has them, but medicine does as well. With all of its issues, don't forget the big picture. That in the end, you are the agent and partner of God in the ongoing act of preventing illness if you can and healing it if you cannot. And then I think that's enough. But that's what I would say to medical students.
I'd say try to revive a principle that is right there in the ethical treatises of Hippocrates, that where there is philanthropia, there will be philotechnia. And that means if the patient knows you care for them and care about them, they will cooperate with your treatment. So if you can manifest concern, and not just pretend to concern, manifest concern, you will have what we like to call compliance. People will actually participate in the treatment regimen that you recommend. And at another level, if people can hear it, as a Catholic, I don't mind quoting an Anglican, or we would in this country call him Episcopalian, a theologian named C.S. Lewis, who said that in your experience, the holiest thing you will ever encounter other than the Blessed Sacrament, which for Anglicans and Catholics is Holy Communion, the holiest thing you will ever encounter is your neighbor. To be able to see the other as the holiest thing on the face of the earth, other than the direct manifestation of God, because the person is a God-bearer, would be a skill which would be good to develop.
I meet with residents on a regular basis, new doctors, and what I try to tell them is the same thing, that you're treating the whole person, that is a person, and get to know that person. And also, don't be afraid to take a little extra time and slow down and stop time for a minute to try to understand where that person's coming from, because we're all so different.
We've now come to the end of our question and answer, and as I promised, we're going to give each of our speakers, perhaps in reverse order, just a few minutes to conclude with whatever remarks they think comes to their heart. Curtis, would you please start?
First of all, I want to thank you, Dr. Hornstein, Community Memorial Health System, for this series, and Rabbi Dorf and Father Dysinger. I want to thank you for sharing this time with me. What I've learned is to be able to assess patients' spirituality and their emotional needs and their families come with positive outcomes for recovery and acceptance of the disease process. And I want to say how honored I am and how privileged that I am that the Lord has put me in the position to do this very thing, to meet people like yourselves and your family members in our community and provide this type of support. I realize what an honor it is to connect with people at such a level, such a deep level. And through this journey, as a hospital chaplain, I feel like that it is very important that we not lose sight of this with the way that medicine is going and the way that we're doing things just what we need. This is something that we definitely need. And as a chaplain, I always want for all spiritual care providers to be that beacon of humanity and love and understanding. So I want to thank you all for coming tonight, and thank Dr. Hornstein again for tonight's presentation.
Thank you.
I'd like to reiterate again that life is a gift, but we also need to recognize that the life we experience on this earth is not an absolute good. That is to say, that this gracious gift that we've been given finds its fulfillment in what will ultimately lie beyond. So we are already beginning to live what you might call the life of the blessed. And the key will be to open our eyes, to open our hearts, to realize that ultimately there are two things that go with us into eternity. One is our relationship with God, and the other is our relationship with one another. And so what we do in the area of bioethics and our interactions with one another, in the choices that we make on behalf of one another, or in regard to our own lives, should be those which enhance those relationships which are destined to exist in an ever more vivid and bright way in the world to come as well. And again, as I said during the lightning round, I think our task is to be able to grow in a capacity to perceive the infinite worth of one another, to interact with one another on the basis of that perception, and to make choices with a real awareness of the tremendous value and the beauty of the gift that we've been given of life, while recognizing at the same time that that life finds its fruition even beyond death, which we need not fear.
First, I mean, I did not get a chance to answer a lot of specific questions about passive euthanasia, active euthanasia, organ transplantation, all of those things at the end of life, artificial means reproductive techniques, abortion, all of those kinds of questions. They're in the book, so if you want, right. But I mean, the topic, though, two things. One is Jews are, even though the Christian tradition got ideas about life after death from us, Jews tend to be much more this worldly centered in their views. And so consequently, the issue of letting go at end-of-life issues is much harder for Jews in many ways. I have a friend who's an oncologist, and he said to me, I said, is there any difference between your Jewish patients and your Christian patients? And without blinking an eye, he said, yes. When I tell a Christian that you have an inoperable brain tumor, they're not happy about it, obviously, but they're going to Jesus. When I tell a Jew you have an inoperable brain tumor, they want a second opinion, a third opinion. Right. So, I mean, it's, what can I tell you? So, I mean, there's a very strong commitment in my tradition to trying to do what you can to stay alive, and Jews only in recent years, I have to say, have begun to understand the importance of hospice, and the importance of understanding when you really do need to let go. The topic tonight is religion and medicine, a healthy or a holy relationship. I think it can be both healthy and holy if it responds to the questions that Dr. Hornstein raised at the beginning, namely not the technique of how do medical procedures happen, but what are the values and the perceptions that a particular religion brings to that whole technique, to the world of medicine, to decide whether you should use the techniques or not.
Wasn't this terrific? Before I finally and formally thank our speakers, there's a couple of other people I just very quickly want to mention. First of all, thank you very much to Mike Ellenson, who is the Vice President at Community Memorial Health Systems, who is here in the back, who has been always gracious in allowing us to have such a beautiful venue and to give us the freedom to have such interesting and controversial subjects, which allows us to look at very interesting and difficult subjects in a community setting. So, Mike, thank you very much for allowing us to continue. I'd also like to very much thank Mary McCormick, who's also in the back. Mary is the manager of marketing, and her wonderful staff who are here today, who have made this, again, just another exceptional evening. So thank you very much for all of you again. But most importantly, ladies and gentlemen, we really must thank our exceptional speakers tonight for taking an incredibly hard topic and really both with humor and with insight and with love really presented that in fact medicine and religion has in fact a very robust, healthy, and holy relationship. So thank you so much to Rabbi Dorff, Father Deisinger, and Reverend Curtin.
All right, sorry.
Pleasure, Father.
Please feel free. Our speakers will be able to be here for a few minutes. Please feel free to see them. Rabbi Dorff, in fact, was incredibly generous to bring some of his books here. He will be sitting in the back and will be more than happy to autograph some of his books for you. I highly recommend that you look at that. And on behalf of the Community Memorial Health Systems and on behalf of the Bioethics Committee, thank you so much. Have a good night and stay well.